We have got to finish in time. If I hurry, please forgive me. This has been an unsolved fracture, as you know. Undisplaced valgus impacted fractures should be fixed in situ. Displaced, unstabilized fractures, natural history is of 100% non-union. Femoral neck fractures in the elderly are associated with 20% of one-year mortality. About 50% of the patients return to their previous level of work and function. Conservative treatment has got little role in this fracture. Only the moribund cases you can think of conservative treatment. Displaced fractures usually require reduction and fixation or replacement. This has been covered by Harish Sharma, older group, low energy trauma, younger group, high energy trauma. We have got this anatomical classification of subcapital, transcervical, and basicervical. Subcapitals are dangerous and usually go in avascular necrosis. Transcervical are divided into three. This has been covered by Harish Sharma, which is the Can you just, where is the pointer here? Pointer. You see the third Powell's type. You have got, doesn't work? All right. Then this type of, is it coming there? Yes. This type of fracture not only requires screws in the line of the neck, but now the thought is that there should be a screw going right across this in right angle, the third screw. So remember that this is one of the points to get good results in Powell type 3. Garden classification has been discussed. Of course, Garden 3 and 4 sometimes require biological augmentation. You must remember in anatomy that when you reduce, it should be a gentle S between the head and the neck of the femur. Vascular anatomy has been discussed. I don't want to go further. Avascular necrosis of femoral head, 15% of neck fractures, femoral neck fractures, even after stabilization, is still reported. References, there's no time for that. Delay beyond 2 to 4 days increases the chances of avian. Then skill in assessment and stabilization technique can reduce the percentage of avian. This has been discussed. I only want to discuss this latter part. Sometimes you don't see this rotation, lateral rotation, as well as shortening. In the stress fractures, pathological fractures, osteoporotic fractures, they complain of groin pain on weight bearing. So we have got to remember that, particularly in old patients. And then sometimes fracture cannot be seen in the laterally rotated X-ray, so you have got to have a special X-ray for that. Diagnostic imaging, AP traction film in internal rotation for correct location of fracture is highly important. Sometimes the fracture is not easily seen. You can order an MRI when the clinical suspicion is high in an old patient. CT in polytrauma is recommended. It's controversial, but if there are other fractures, CT is recommended. Bone scan is not positive before 24 to 72 hours, so you cannot use it as a first line of investigation, but useful for pathological fractures. Differential diagnosis, these are whole host of them: intertrochanteric, anterior pelvic ring fracture, hip dislocation, femoral head fractures, pathological lesions, including neoplasm, infection, arthritis, avascular necrosis, contusion, muscle strain. These are all come into the differential diagnosis. Indications for, is there a role of non-operative management? Yes. Non-ambulators, people who are not moving, neurologically impaired, moribund cases in extremis. Some valgus impacted fractures discovered late. Even then, there is a 46% of non-union. Stress fractures sometimes, people who have been walking and develop this, and osteomalacia, you can wait to do. And the treatment is listed on the right side: bed rest, limb traction, prevent bed sores, pain management, supportive care, and mobilization after the pain control. Surgical management: most patients with femoral neck fractures should be considered for surgical treatment. One should not accept a less than perfect anatomical reduction. This cannot be stressed enough. Fixation in situ for non-displaced, valgus impacted, and the stress fractures. Open reduction, internal fixation, high energy displaced fracture. Non-displaced fractures, subcapital, transcervical region, lag screws can be used without opening the capsule. And then basic cervical fractures should be fixed, angle, sliding, hip screws, or cephalomedullary nail. Hemiarthroplasty in displaced fractures in elderly or THR, osteoporotic neurological disease, arthritis, and other comorbid conditions. Preoperative planning, optimization of medical care, cross consultations, delay in surgery beyond 2 to 4 days increase the risk of perioperative complications and length of stay. Good quality radiographs for location and orientation of fractures are necessary. Contralateral site should always help in selecting an implant with the correct length, diameter, and neck shaft angle. Image intensifier. Image intensifier also is necessary. Instrumentation implant should always be checked before surgery. Otherwise, you find that when you want a particular implant, it's not available. Prophylactic antibiotics, chest physiotherapy. And last but not the least, please observe that the theater is air sterilized. Just Sudhir Kumar was saying that I have got a good, clean theater. Congratulations to him. Patient positioning. Positioned with both hips extended and contralateral hip is abducted for C-arm, and the C-arm is between the legs. Close reduction can be obtained by applying gentle traction and internal rotation under fluoroscopic control. Avoid vigorous maneuvers like Leadbeater's. If reduction is difficult or imperfect, even after trial, open reduction, you should not hesitate in doing it. Reduction should be anatomic, and contours of the head and neck are established, as I showed, the S, gentle S angle. Standard lateral approach for percutaneous, we are doing percutaneous techniques now, minimally invasive fixation or minimally invasive fixation of non-displaced valgus impacted fractures and well-reduced displaced fractures. We use lag screws. Open reduction for irreducible fracture, Watson-Jones approach, and Smith-Peterson approach. Watson-Jones for relatively thinner patients, it's an inverted T triangle with the lowest screw just at the level of the lesser trochanter, not below, and the other two skirting the cortices of the neck, and use from proximal screws washers because they are in the cancerous bone. The Watson-Jones approach, here is the incision, this is the anterior superior spine, this is the tensor fasciae lata muscle, and here is the line of incision. This is gluteus maximus, and this is tensor fasciae lata in front. And then this is the capsule exposed. You have cut the reflected head, and here is the capsule opened, and you can use this inverted T fraction manner and use a joystick of K-wires or a Schanz pin. Smith-Peterson's approach is for more heavy patients, and it is from the anterior superior spine the incision goes towards the lateral side, lateral patellar line. The length sometimes have got to be increased in obese patients. DHS plating for busy cervical. And this is one of the examples where hemiarthroplasty for a failed neck of femur with avascular necrosis after the internal fixation. Pearls and pitfalls. Imaging. Recognize the pattern of injury through X-ray. Traction and rotation APV is necessary. Negative X-ray but high degree of suspicion, you can order MRI. Polytrauma cases, CT is advised. Position of the fracture. Torso should lean to the opposite side of the operated leg so that the pelvis is stable and not rotated or tilted. Patient draped wide from ribs to the knee for complete access, just in case the small approach will not help. Okay. The reduction, the pearls or pitfalls are gentle traction and internal rotation to reduce fracture. Guide pins, threaded shank pins used as joysticks to help reduce fracture in open reduction. Good muscle relaxation is necessary for anesthetists, and anatomic reduction is necessary. If reduction is not perfect, open reduction. Avoid making hole below the lesser trochanter. Screws should be positioned against the femoral neck cortex. High angle Powell's 3 fracture, additional horizontal screw or sliding hip screw or cephalomedullary nail. Tip affect distance should not be more than 2 centimeters. Post-op, weight bearing allowed as tolerated, DVT prophylaxis, antibiotics, this has been covered. Outcomes, femoral neck fractures in the elderly are associated with about 20% of 1-year mortality. About 50% of patients return to their previous level of function. The quality of reduction is the most important surgeon-controlled factor in the outcome. Biological augmentation for delayed open reductions is welcome. Thank you so much.